My name is Lauren de Kock. I'm a Regional Director at the Aurum Institute of Quality Improvement and Clinical Training. I am presenting on how activities are designed for failure. Controlling the HIV epidemic will not become a reality until there is a drastic shift by funders, national and local ministries of health, and non-government organizations from implementing a barrage of uncoordinated activities to a deliberate focus on strengthening and redesigning the systems of delivery. I have noted in my 20 years of experience in the South African health sector, largely focused on the delivery and improvement of HIV and TB programs, a critical gap in healthcare workers and managers' ability to apply a systems approach to the delivery of healthcare services. There tends to rather be an overemphasis on the large-scale rolling out of work plans and so-called innovative activities, many of which fail to consider and or address the complexity of delivery and the design of the health system that influences and directly impacts the delivery of these activities. If activities are deemed effective in other settings or appear to be based on sound scientific evidence, how these activities are implemented within context is a critical, ongoing exercise that cannot continue to be neglected if we are to reach epidemic control. Dr. W. Edwards Deming defines a system as being a network of interdependent components that work together to try to accomplish the aim of the system, not identifying, focusing on, and strengthening the components or the system's interdependence will lead to a health system that is designed for failure. Poorly designed health systems, done so deliberately or subliminally, will consistently produce substandard results, despite our very best efforts. There is little coordination amongst frontline workers and managers responsible for the health sector. There is therefore an urgent need to ensure that all aspects of service delivery have been thought through, assigned, done correctly, recorded, reported and continuously monitored and adapted as required. Currently, there are many who draw on quality improvement methodologies to improve the delivery of HIV services. Many of these improvement initiatives, however, are implemented as standalone projects, focused on trying to effect change in a specific process or activity. They have a clear start date and end date with activities well defined. While most of these activities in and of themselves are critical and needed, not defining their implementation within the context of the current health system and addressing the many drivers for program implementation excellence sets these activities up for failure. In trying to identify why quality improvement initiatives in South Africa have been largely unsustainable with minimal impact, I have identified 7 high-level causes, most of which stem from a lack of understanding and application of systems theory. I have noted that little has been done to create a culture of learning and improvement outside of a project framework, which addresses a routine way of incorporated problem identification and solving into everyday work. I currently lead the quality improvement work for a national project management unit called Operation Patuma that exists to support the National HIV Directorate in South Africa. In an effort to better coordinate and manage the rollout of activities across the country with the aim to reach the UNAIDS what was then the 90-90 targets and is now the 95-95-95 targets, Operation Patuma formed a coordinating bodies, or also known as nerve centers, in provinces or states around the country. Voicing my concerns about the lack of a systems approach to our implementation, my team and I were tasked with developing a revised strategy to problem solving and implementation that would be utilized by these nerve centers across the country. The 7 challenges I alluded to earlier, which were impacting on why South Africa had not benefited enough from previous quality improvement initiatives, were used as the basis for the design of the now referred to as the new nerve center approach. I will go through each of these 7 challenges and show how they have been used to inform a new improvement strategy to nerve centers that moves away from a project approach to one that considers and strengthens the health system on an everyday basis as part of everyone's job. Not surprisingly, the first challenge deals with managers and healthcare workers' inability to see the health sector, their clinics and or hospitals they work in, as a system of related parts, all impacting on each other, how they do their work, if they do what is expected, and quite frankly, if they do not, all have an impact on seemingly unrelated functions and people in the health system. Implementation of activities is therefore often done by individuals in one unit or department with little to no coordination with others. I have noted that this is often not a deliberate attempt to exclude, but rather a spin-off from the lack of understanding that health is a system that's either designed for success or failure. As a result, there is no shared sense of problem solving or accountability. Problem number 2. When working in silos, we inadvertently create a blame culture. And the only way implementation or problems are addressed is by getting the people who so-called created those problems to address them. This leads to the third identified challenge, which is a workforce that is often observed as disengaged, frustrated, and unsupported. Trying to push a workforce to work harder without addressing the health system can only but leave them feeling disengaged, frustrated, and unsupported. It is no wonder then that my fourth identified challenge was a firmly held belief across the public health sector that quality improvement was not part of their jobs, but rather something that belonged to funding agencies. Fifthly, data, if and when used, is primarily for the purposes of reporting. There is little identification and engagement with data elements that help to explain and define how work is being done in a complex system, or use of data to identify problems and causes of the implementation gaps. The last 2 challenges I identified speak directly to managers. I noted multiple uncoordinated demands, interventions, structures, processes, and resources aimed at facility level, with little to no coordination between units, divisions, and programs. This caused confusion, blurred frontline workers' ability to prioritize, and directly impacts implementation, as there are no clear guidelines, standard operating procedures, and coordinated instructions given. A manager's role from facility to national level is often misconstrued as a corrective function, instead of an opportunity to provide supportive supervision within the problem-solving and implementation process, as well as a duty to address drivers to change when unpacking the complexities of implementation within the health system. Lastly, I noted a glaringly obvious lack of standardization in the implementation of activities. If a province or district was supported by a funding agency, they were more inclined to have some sort of improvement science methodology utilized. However, this too was not standardized across supported areas. Tools, templates, and approaches were implemented with huge variation, despite many practices being known and documented. The nerve center approach, cognizant of all 7 challenges, was therefore designed to move away from project-based improvement efforts to create a culture of everyday improvement. This was achieved by introducing changes at 2 levels, facility as well as management. At a facility level, indicator teams are formed and specifically focused on a single indicator or family of indicators' performance. The multidisciplinary team, chosen by the facility, have a diverse understanding and experience of the health system. They meet in weekly huddle meetings to review their performance data, to identify problems, discuss possible interventions, and monitor and adapt changes being tested. They are provided with specific standardized data collection tools for each nationally prioritized HIV indicator that help identify specific challenges in their own health system and guided to tailored interventions to address these gaps. There are 2 main tools that we designed and tested to achieve this goal, and I will discuss each one briefly now. The first is the step-by-step assessment tool, which provides indicator teams with the essential processes and steps needed to implementation success. Conducting the step-by-step indicator assessment helps to identify steps that are missing or not completed correctly in a facility's implementation's processes of work. These gaps are contributing to the indicator's poor performance. Each step-by-step indicator assessment has an indicator definition that highlights the content of that tool. Color-coded sections divide the tool into specific areas for assessment. Each colored section has a sequence of steps that need to be followed. These guide the user to know what information to collect, calculate, or query to understand the current indicator's performance. Findings or evidence gathered from the assessment are recorded under the evidence column. The evidence can be in the form of comments or numbers. In preparation for the assessment, the team should identify the source documents that will be used for the data collection and record it in the source column. The assessment objective column states the purpose or reason why the assessment is being conducted. This provides better understanding and insights for the team who are experiencing the problem and not meeting their targets. The second tool is called an indicator summary chart. This chart provides a quick overview of and the space to capture all the data elements that contributes to a specific indicator's performance. Looking at these data points side by side over time allows indicator teams to develop a more accurate understanding and theories about their current performance, make informed data decisions, and therefore more effectively plan for improvement activities. It is the responsibility of the Operation Phuthuma indicator teams to collect the data on a weekly basis. The data from the summary chart gives the team an opportunity to dig deeper and provides a detailed view of the specific data for each element that is impacting the performance of the indicator. Each summary chart has a detailed analysis guide that assists indicator teams to examine their weekly data to identify opportunities for improvement. The indicator summary chart and step-by-step indicator chart complement and support each other. They are color-coded so teams can easily identify the synergies and opportunities for improvement. If the indicator team has picked up a problem with their data in the green section of the summary chart, then they should follow the steps in the green section of the step-by-step indicator assessment to identify the steps in the process that needs correcting. Creating a structure for teams to work together with standardized tools that give specific direction and insight into how their system functions and is designed gives teams the opportunity to work together to understand and solve implementation challenges. It breaks down the blame culture and begins to empower all healthcare workers as valuable and needed members of a team. Witnessing counselors and data capturers take charge of clinicians while directing their indicator teams has been energizing and empowering. Implementation is complex, and facility-level staff need support, direct guidance, and standardized tools to assist them to demystify these complexities, make sense of their data in order to use it to make implementation decisions, and work together to consider all the aspects of implementation and not just the ones they have charge over. Shifting gears now to a management level, our interventions are focused on introducing 3 changes. The first is refocusing the purpose of managers to be supportive rather than only a corrective role. Management cannot only take place via email or behind a desk, but going to facilities and being part of the team as they grapple with implementation is a critical management role. We have therefore designed a supportive supervision tool, which managers use when conducting facility-based visits to guide them in what they should be looking for, asking, and offering. This addressed a critical gap that we observed, that many managers are themselves uncertain of their role and purpose when visiting facilities. Secondly, we have adapted the WHO building blocks to create what we call drivers of program excellence that give managers specific areas to strengthen and address when considering the design and rollout of a program. Each driver has been adapted for priority indicators, and we give suggestions of specific activities and content that needs to be considered under each driver for each priority indicator. This is used in program design and adaptation by program managers. Thirdly, we have restructured the way nerve center meetings are run. An agenda template is used to mentor management teams to move away from simply focusing on reporting towards a more robust discussion on problems, causes, data elements, spread of tried and tested activities, and of course, sustainability. We provide mentorship to management teams as they make this transition. To date, we have rolled out this approach to 4 of the 9 provinces in South Africa. We have trained and mentored a total of 459 master trainers who are responsible for rolling out the approach in their own province and district. Master trainers are not customary trainers who train by profession, but rather managers with specific responsibility for the performance of districts and facilities. This distinction is critical when a culture change is sought and not simply the mass rollout of an activity. A total of 1,825 people have been trained on the approach, reaching over 400 facilities in the country. My team and I have conducted over 500 supportive supervision visits with managers in all 4 provinces and assisted in the formation of restructuring of over 40 management level nerve centers. The approach has not yet been formally studied to determine impact. This is planned and will take place next year. However, through our intimate and extensive engagement at both facility and management level, we have taught, mentored, and demonstrated. We have noted a fundamental shift in the way people engage with each other, their problems as well as their data. We have witnessed how disempowered staff are energized by their ability to take control of their problems, simply because they now know what is causing them, what to do about them, and have the tools to manage the processes and know that they now do not do this alone. Managers are re-engaged and have tools to guide the decision-making process, feeling like active contributors and not feared law enforcers. Change is slow, complex process requiring a lot of adaptation according to need, circumstance, ability, resources, and desires. Our new nerve center approach is based on empowerment and sustainability, which is why we work with each province individually and over time. This new approach seeks to change the way healthcare workers and managers do their work every day to routinely address how the system operates and is designed so that activities are more enabled to succeed. Incorporating this foundational approach to work is a far more sustainable and integrated way of working. Once this foundational approach has been incorporated into routine work, a more specialized QI approach can be applied. However, until a conscious effort is made to strengthen our health system by working together and using data to make and monitor improvement, we will continue to design activities for failure, and the hope of reaching epidemic control will never be realized. Thank you.